endometriosis, another leading cause of infertility. 35% of cases of infertility are diagnosed to be are due to endometriosis. So basically, endometriosis is when the uterine tissue implants and grows outside the uterus, affecting the function of the ovaries, uterus, or tubes. Now, this tissue, it forms like a scar tissue, and it can block the fallopian tubes if it gets implanted at the level of the tubes, or if it's in the ovaries, it can form a big endometrioma. So if an endometrioma is there, again, because it's an inflammatory lesion, so when this endometrioma is present in the ovary, it disturbs the ovarian milieu, and then the existing eggs, they are of compromised quality, or of poor, you get a poor egg quality in such patients. Again, PID, like we have discussed, again, recurrent infections of the female genital tract can cause endometritis, that is inflammation of the uterine lining. Again, tubal salpingitis, that is inflammation of the tubes, or tubo-ovarian abscess and peritonitis in cases of tuberculosis. Uterine fibroids and pelvic adhesions. Ovarian failure can be a risk of few medical treatments, or complete failure of the ovaries to develop or contain egg in the first case. Now, see, ovarian failure can be due to genetic causes. If there is a patient with Turner's syndrome, or if there's a patient with Swyer syndrome. So yeah, this Swyer syndrome patient is not going to have, is going to have streak ovaries. Of this a patient with Turner syndrome, or a patient who's having, premature ovarian failure, her ovaries have failed. They have stopped responding to the FSH and LH hormones in your body. So these patients need to go for third party donation, or they need to take help from another female, like egg donation from another female to conceive. Ovarian failure can also be due to certain medical treatments, like chemotherapy or radiotherapy, which are given to cancer patients. In such cases, these treatments like chemotherapy and radiotherapy are gonadotoxic. So in males and females, in both, they are gonadotoxic. So these treatments are going to fire their ovaries. Hence, when a cancer patient is consulted by an oncosurgeon or an oncologist, they first send it to us as a fertility specialist for fertility preservation. In these cases, we have to cautiously stimulate these patients, because again, increase in the level of estrogen can also fulminate their if it's a estrogen positive, receptor positive tumor, then it can cause fulmination of their cancer pathology. So hormonal disorders. So like I said, it's thyroid dysfunction. Now, if there is thyroid dysfunction, obviously hyperprolactinemia can occur. So thyroid and prolactin go hand in hand. Vice versa, if there is prolactin levels are raised, then again thyroid dysfunction can occur. Now, thyroid and prolactin, if not controlled, they can again affect the process of ovulation, the process of formation of a healthy egg, the process of implantation. And obviously, as we all know, thyroid and hyperprolactinemia can again called menstrual disturbances. Hence, these hormones have to be corrected and evaluated firsthand. PCOS, I'm going to discuss this in details, and premature menopause or premature ovarian insufficiency, which we already talked about. So PCOS is the most common endocrinological disorder, and we see 1 in 10 women who present with this disease. So it is the most common cause for infertility, and it is the most common cause of menstrual disturbances in adolescents, women in the reproductive age group, and again a leading cause for risk of endometrial carcinoma in later ages. So a lot of couples come and ask me, ma'am, do we have PCOD or do we have PCOS? Now, let me tell you, ESHRE, that is the European Society for Reproductive and Human Reproduction, has said that PCOS, PCOD, PCOM, all are one and the same thing. They are not different terminologies. So it is a heterogeneous disorder of unknown etiology. Now, why does PCOS occur? There is not a single definitive cause for it. There are a lot of theories with respect to PCOS, and we have categorized PCOS into different categories on the basis of the presenting symptoms. So it is the widely accepted diagnostic criteria which we clinicians follow is ovulatory dysfunction, which means irregular menses, clinical or biochemical signs of androgen excess. What are clinical or biochemical signs of androgen excess? That is hirsutism, that is male pattern hair growth all over the body or face, or male pattern baldness in females. Biochemical signs, as in if you do the testosterone levels, androstenedione levels, or DHEA levels, they are raised in these patients. The serum hormone binding globulin levels are low in such patients. Or PCOM, and which means on ultrasound, on transvaginal ultrasound, there is evidence of polycystic ovaries. So any two out of these three are present, then that patient is termed as PCOS. So what are the four different types of PCOS? One is insulin resistant PCOS. In this, what happens is the patient develops insulin resistance. If this patient is obese, again, it is going to add to it. So if there is insulin resistance, the glucose is not going to get broken down and it is going to get stored as fat, and again that patient is going to gain weight. So because there is insulin resistance, the increased amount of insulin again goes and acts on the ovaries, and asks the ovaries in turn, in response to this insulin produce more amount of male hormones, hence leading to insulin resistant PCOS. Post pill PCOS, if somebody was on OCPs for a long period of time and she had that genetic variant for PCOS, so because of this insult, that is, you have used OC pills for a prolonged period of time, this genetic variant of PCOS can get triggered and she can end up having a full-fledged disorder. Inflammatory PCOS, this is basically inflammatory PCOS, as in basically there is gut leakage, if you've heard about it. So if you eat any inflammatory food, so gut dysbiosis is there is gut dysbiosis, and hence there is a state of inflammation in your organs, and your ovaries, again, due to this inflammation, will produce more amount of male hormone, hence imbalancing the female hormones, leading to PCOS. Adrenal PCOS, this is also stress induced PCOS. If you are again, if you have the genetic variant for it, if you are under a lot of stress, that is chronic stress, the level of cortisol in some amounts is good, but if you are under chronic stress, the cortisol hormone is going to get produced in excess, and hence, because the cortisol hormone is getting produced in excess, your male hormone gets triggered, your male hormone gets produced in excess, hence leading to PCOS. So depending on the types, like on the presenting characteristics, we have divided PCOS into 4 types. Type A is classic or severe PCOS. Now this group of patients are the one who need a lot of help while conceiving. In this, all the 3 signs of diagnostic criteria of PCOS are present. That is, there is delayed ovulation or no ovulation at all. That is, menstrual disturbances are there. There is signs of hyperandrogenism or androgen excess, and polycystic appearance on sonography. Type B is classic PCOS. These patients might, favor with small lifestyle modifications or small help of medications. So in this, only 2 criteria are present, that is menstrual disturbances and signs of androgen excess. The ovaries might appear normal on USG. Type C or non-classic ovulatory PCOS, in this, that this patient will have regular menses. Now, in such a case, you have to remember, if this patient has other 2 criteria of PCOS, that is signs of androgen excess and polycystic appearance of ovaries on sonography, and if she has regular periods, it does not always mean if she's having regular periods ovulation is always going to occur. Ovulation, as in the egg, may not be mature in her case, so this patients will also face certain amount of difficulty while conceiving. They might get regular periods, but the egg, their ovulation is occurring or not, that is questionable. Type D, that is mild PCOS, where there is menstrual disturbances and polycystic appearance on sonography, but no signs of male pattern hormone excess.